we have now paper from Austrian colleagues. Better safe than sorry, unmet needs for healthcare during the COVID-19 crisis in Austria. Who will present?
Yes, hello everyone.
Hello.
I'm glad to have the chance to talk today. I'm trying to share the
Andrea,
slides.
please. Okay.
Is it visible?
Yes.
Okay, great, perfect. So I'm going to touch upon some of the things that have been discussed in the morning session, and I think Francesca's presentation was a nice complementary side to our work. We are also focusing on one country, in particular on Austria, and on subjective unmet needs in healthcare during the first wave. This is work done with Ricardo Rodriguez and Cassandra Simons from the European Center for Social Welfare Policy Research, and with Nadia Steiber from the University of Vienna and the Institute for Advanced Studies. My name is Andrea Schmidt. I'm a senior health expert at the Austrian National Public Health Institute, and I'm very pleased to be able to present to you this work. Let me start with a definition. So subjective unmet needs for healthcare measures a gap between the services that you as a patient judge necessary to deal with your health problems and the services that you actually receive. And it's opposed, of course, to clinical assessments that are done by an external person, but the advantage is that it also involves an element of personal choice and personal preference, of course. As you all know, the pandemic has had an unprecedented impact on European healthcare systems, and in particular for non-urgent treatments. We've heard this now for Italy. There are also a lot of other studies that look at, for example, inpatient and ambulatory care settings. But most of these studies look at do not differentiate between different groups of patients and population groups. In Austria, at the aggregate level, for example, we saw a large drop in hip and knee surgeries of about 80% in April 2020 compared to April 2019. Now, as you know, the pandemic has had also a great social impact, which is why some authors have called it a syndemic. And we know also from previous crises, and this is an important point I would like to make. So for example, in the crisis in 2008 and 2009, we saw that there was a large effect in terms of an increase in out-of-pocket payments and reduced availability of services, in particular due to cuts in public health budgets. And that has led to an increase in subjective unmet needs in the population, but in particular among, for example, unemployed persons and people with lower income. Now, our argument is that the COVID-19 crisis is different because it has led to a sudden drop in the shift of resources in the healthcare system. And it was a relatively indiscriminate supply side effect on healthcare system. So the supply with services was cut off from, if you like, from one day to the next, and basically for all patients or for many patients. Let me say one word about Austria. It has a social health insurance system and a strong focus on inpatient care, but with a high coverage of social insurance. About 99% of the population are covered. At the same time, there are moderate to high out-of-pocket payments. And the country took quite quickly stringent measures. It was also shown in the presentation by Waltraud before, but it also loosened these measures relatively quickly. In the care sector, so in the healthcare sector, there were no official guidelines as to which patients should be prioritized and how these services should be shifted to reserve capacities for COVID-19 patients. And this resulted in a very, very restrictive and I would say overly restrictive access to inpatient care, especially at the beginning of the pandemic, and also large variations in ambulatory and its availability, of course. The objective of the study was, on the one hand, to compare unmet needs during the pandemic to a pre-pandemic baseline. We call this the excess subjective unmet needs, and to analyze also how the subjective unmet needs that we find were systematically related to socioeconomic status or other personal characteristics. We differentiate here different reasons for barriers or for unmet needs that were found at the system level and also at the individual level. I'm going to mention this a little bit further in one of the next. We used novel data from a representative survey in the working age population in Austria that looked at the social impact of COVID-19, and we focused here on the healthcare part. And for the pre-pandemic baseline, we used the European Social Survey that includes the same question regarding unmet needs for the reasons that were not related to the pandemic in particular. We used, except for the first part, we used in the first part we did a simple comparison, and in the second part we used the multinomial logistic regression model, and where we adjusted for age, gender, and socioeconomic factors, as well as importantly self-rated health status. And we did also gender analysis, so we did the models also separately for men and women. And we investigated also the dynamics with the self-rated health. Now let me say one word about how we operationalize this subjective unmet needs. It's foregone medical examination or treatment since the beginning of the pandemic that was perceived as needed. So in June 2020, patients were asked, did you have any medical examination that you had to forego or any treatment that you would have needed? And what this data allows us to do is also to distinguish who had needs and managed to access care, whereas compared to those who did not have any care. And we can then distinguish 4 groups, people who had a need and received care, and then importantly, people who reported subjective unmet needs that due to reasons that are related to the pandemic. What do we mean by that? So related to the pandemic in this context means that you experienced subjective unmet need because you were afraid of infection at the provider was closed, or the treatment was postponed. These are the 3 reasons that are that we call the COVID-19 related unmet needs. And then we have the conventional reasons like financial barriers, knowledge, lack of knowledge, waiting times, reachability, and time. And of course, the group that did not have any unmet needs, but received care that they would have needed. Now, I'm already moving to the results. As you can see in this graph, we have quite a substantial increase in subjective unmet needs during the pandemic, and mainly due to reasons that are actually related to the pandemic. So I said before, these are fear of infection, the provider was closed, or the treatment was postponed. And this is a strongly significant effect, and it rose between 2015 and 2020 from around 6% to 20%. We had seen in the presentation by Hans in the morning that across Europe it was around 18%, so we could say it's relatively similar, but of course we cannot directly compare these data. If you look at specific groups in this comparison with the pre-pandemic baseline, we see that in particular people who are inactive or retired, people in older age groups in our sample, and people with poor or very bad health, as well as people who have difficulties in making ends meet, are the most affected by this increase in unmet needs due to the pandemic. And we see also that there is a significant effect for all, or there's a significant difference in comparison to the pre-pandemic baseline. Now, let us look a little bit closer. What were the reasons? So some might say, okay, probably people were afraid of having an infection, but actually that's not true. That's not what our data says. So the main reasons why people experienced unmet needs was because actually the provider was closed or the treatment was postponed. And from a policy perspective, this is quite interesting. And it's also interesting to look then, of course, what were the groups that were most affected. And we see, for example, that postponements occurred especially in people with poor health, in older age groups, and people in retirement. So these, of course, it's hard to disentangle also these effects. And the closed providers were hit people with poor self-rated health status and people who were unemployed. Financial reasons, as said before, so financial reasons were a big topic in the previous crisis, for example, the financial and economic crisis in 2008 and 2009, but this was very, very low in our sample. The highest value was reported by unemployed. We are now moving to the multivariate analysis. So we want to control for demographics, financial well-being, and self-rated health status. And I'm going to move directly to the table. So you have here the multinomial regression results, the average marginal effect. So the higher the effect, the larger is also the barrier that you experience or the unmet needs that you experience. We are focusing on the second column in the first place because we want to know how did the pandemic, so the reasons that are directly related to the pandemic, and how did these affect different groups. We see that especially older people were affected. So the group in the age group 50 to 64 years was affected. We see again that this effect also was strong. So barriers occurred for people who were inactive or retired, and people who did not have good health. And in addition, we see that women and people with secondary education experience more barriers. All right, so I'm not going to show the gender results in this presentation, but I will move now to the next aspect of our analysis, which refers to the dynamics of the self-rated health. If you look at this table, you see in the bottom line, the bold coefficients or marginal effects, that the effect of poor self-rated health status was very, very strong. And it was very strong in particular in the group that had COVID-related unmet needs. And so what we did is we looked at how the level of poor health or good health affected also the interaction, so the effect of the other characteristics. So let me give you an example. So you see here 3 panels. On the top left panel, you see in the x-axis age, and you see that in general the COVID-related barriers are increasing the higher your age is. And then we see also that for people in poor health, this effect is larger overall, but we see also that in particular, the people in older age groups are significantly more affected if they're in poor health. So we find a small interaction. What is interesting and what makes this crisis potentially different from other crises is that the financial hardship is so there we see parallel lines, and there's no difference depending on financial health status. And finally, we did not find an effect for unemployment by self-rated health status, but only for the inactive and very small effect for people who are retired. So again, people who are inactive and in poor health, they are very likely to experience this type of barriers. Let me sum up before I conclude. There has been a very stark increase in the unmet needs in the pandemic due to postponed treatments, closed providers, and fear of infection, even though the latter reason is not very important in our sample. And unlike in other crises, there were no differences found by financial hardship status. So people who have difficulties in making ends meet did not report more barriers. And poor health is a consistently very, very strong predictor. And we also find some indication of some kind of a double vulnerability. So if you're in poor health and excluded from the labor market, for example. And the same holds also for older age groups, even though we have been looking at working age population. So the oldest age group that we have in our sample is 50 to 64 years. There are 4 key messages. The tripling of unmet needs that we find in our sample raises concerns that go beyond the pandemic. It raises concerns about how this is going to affect those mid to long-term consequences for health, as well as for public health budgets. So is the demand going to rise because treatments were foregone, or because medical needs continue to exist and worsen? The question is also, why did we not find a socioeconomic effect? For example, could it be that people, even if they had a larger network or more contacts or social capital, were not able to find care because of the sudden and indiscriminate restrictions in access? But we see a new vulnerability, so poor health and exclusion from the labor market. And finally, older age groups. This has been discussed quite often already in the course of today. And I would like to maybe also raise a point for the discussion. So could it be that it's not only that older age groups were not only affected by unmet needs more because of restricted access in general, but also because they have a higher risk of needing intensive care? And actually the point of the lockdowns and of the restrictions were that to reduce intensive care needs. So the question is whether there has been also a kind of invisible effect of deprioritizing older people even further. So when the doctors and at the hospital level, when people had to decide who they're going to postpone and who not, could it be that actually older people that would have a higher risk of requiring ICUs were deprioritized even further? It contradicts a little bit what Francesca found, I think, and it would be interesting to hear more also what you think about this. To conclude, we think that one aspect that contributed to the situation in Austria was that there was no preparedness plan for hospitals and ambulatory care, so there were no guidelines issued, and also that the role of primary care was underestimated in Austria in general. So in other countries like the Netherlands or Slovenia, primary care was much better integrated in the whole response. What is surprising is that we didn't find socioeconomic effects, because the negative financial impact is showing already at the beginning of the crisis when we collected this data. Of course, this is something to be observed, because it's very likely that in the mid to long term, out-of-pocket payments are going to increase as the pressure on public health budgets is also going to get worse. Let me thank you for your attention, and if you have any questions, please do not hesitate to ask. Thank you.
Thank you, Andrea, very much. Indeed, there are a few questions in the chat, but I will get back to the questions once we have heard from our discussant today, Peter. Yes, go ahead.
Yeah. So the second paper, well presented by Andrea Schmidt and of her co-authors. The summary. This is so yeah. Just picking out the key points. This is a representative population survey. So that's one way it's very different from the first paper. Although it's about healthcare access and stuff, it's not a sample of people who are using hospitals, like who are only using hospitals and stuff like that. And it uses data from the European Social Survey in 2015, and the idea is to make these comparable samples. The main outcome is the subjective unmet need, which is measured in this 2015 survey as well as in the 2020 survey, and has some covariates and analysis using multinomial logic. Okay, so some of the, this is the descriptive, some of the things that are pointed out nicely. I mean, some of the interesting things is that there was, in 2015, we had this measure of unmet need, and we can see the non-COVID unmet need in 2020, which, so this was like a nice part of the paper that you could measure the excess, so how much unmet need that was due to the COVID, but at least we know like what proportion of that would have happened anyway. So I thought that was a nice feature of the paper, that you have those aspects of it. The age factor I'll come back to. I think that's interesting here. There's like sort of lack of age gradient in unmet need is in 2015, and even in 2020 to some extent, there is a bit more of an age gradient there. It's interesting. Okay, so yeah, so again, picking up some really interesting results here about the fear of infection was quite low as a contributor to unmet need, just in the descriptive statistics. This is a sample of people that are all under 65, which I thought was a curious sort of definition. I wonder why the authors have chosen this, because you know, if we think about people needing healthcare, like there's quite a lot of people over 65 need healthcare. So I was just wondering why it's like working age adult population. And there's no age gradient in healthcare utilization in this group of patients, which I found astonishing. That older group of older, in fact, they're not patients. The older part of the population are just as likely, in fact, even slightly less likely than the younger, to have needed and had healthcare during the past year. So I think that was a sort of question I had on that. We can see that financial barriers were small as a determinant of unmet need. Also, obviously, there's a universal healthcare system. Whereas the treatment postponed was like the larger determinant of the COVID unmet need, which is what we would expect. Just in terms of the fear of infection being a small one, I just draw up some other data I'm aware of because I'm doing research on emergency care in the UK, and there's been a very large drop-off in people using emergency care in the UK, probably in other countries too. So about half at the moment, when the pandemic has been particularly bad, people using emergency care has been down to almost like half as much as normal, which has been, people have put that down a lot to fear of fear. So I think that's an interesting question to address. Why does fear not seem to be such a big driver of unmet need in this group? So yeah, you mentioned the self-reported health being an important determinant in the multinomial models. I will keep going. On employment status, so you find this large effect of being inactive rather than being unemployed, inactive or retired. And I think that makes sense in terms of if you think of some of these patients having cancer or needing hip and knee replacements, a lot of them may not be working due to their health condition. So that would be like disability related, not working, or they're going to be retired. So they're going to be post-retirement age. So that makes sense to me in terms of just the age profile of people who've had their operations cancelled, essentially. I thought that could be brought out more. Okay, and so my general discussion points of things I've mentioned throughout. I think the comparison of unmet need between COVID and non-COVID reasons and being able to compare that number with like a previous estimate from 2015 is a strong element of the paper. So that's a sort of a good thing to emphasize. Fear of infection seems to play a small role, and why is this? So it'd be interesting to talk about that a bit more. Age, I've got, as I described there, I've got some questions about what's going on with age. Why doesn't age seem to be a determinant of the met need? So the patients, just health in terms of patients who have been using healthcare in the last year, and why is there no over 65s? And for the younger patients, for the 20 to 40-year-olds, for example, why are so many of them reporting unmet need? Because you would think not so many of them would be using healthcare. So I'm wondering about that. The introduction states that 80% of hip and knee replacement procedures were cancelled in April 2020. So to me, all of the results seem to follow from that, explaining the results, basically. That sort of cancellation of elective procedures is the main driver of the results. We've got older patients being more affected in terms of the unmet need, labour market inactive people being more affected, unemployment and income not playing such a big role. It wasn't like the hospitals were then selling their operations to the highest bidder after these cancellations were happening. So the price mechanism isn't playing a role here. So it's not income and that sort of thing is not playing a big role. So that one made sense. Suggestions for improvement. So I didn't have so many suggestions for improvement. The paper is very clearly written and explained. I think there could be improvement in the interpretation of the multinomial logit models, because there you've got these different outcomes and they're sort of mutually exclusive outcomes, and sometimes it's hard to interpret because you're really interested in the unmet need, but you've also the opposite outcomes you've got are met needs, so patients who did have healthcare, and patients who just didn't need healthcare at all. So that could be clarified. Again, I've mentioned several times, why is there no age gradient in healthcare utilization? And in terms of your using this old survey from 2015, I think it's good, but you maybe need to defend that bit more clearly in the paper. So maybe use some more statistics from the surveys to sort of justify that this is comparable to your survey you've done in 2020. That's it.
Thank you, Peter, very much.